Well, good morning. Thank you very much for the invitation. Thank you, Aida. I have been working together with you for many years and your siblings as well. It is a pleasure that a day like today, a speech therapist is invited to speak. It's not so frequent, as you mentioned, in the MDTs, multidisciplinary teams. I've been working in hospitals with these MDTs, and speech therapists tend to be called for sort of a cooperation within these teams. So I'm just going to talk about what a speech therapist role is within a MDT in Wilson's disease, WD.
A ver, en la enfermedad de Wilson, como sabéis, los pacientes que presentan afectación neurológica presentan una alteración en la musculatura que rige todos los movimientos que nos hacen hablar y nos hacen fonar, es decir, que salga la voz. Y también estos mismos músculos, estos mismos movimientos nos ayudan y nos...
These muscles help us to swallow. That's what we are talking about, these two involvements, speech and swallowing. So when we talk about speech, we're not talking just about talking. We are talking about writing. So we get these micro writing difficulties to write properly. And even though today's technology helps us, I don't know how many of you are writing by hand, probably not many. So this feature today is probably not so important since we don't really write that much. And if we do, we have technology to help us. The gestures are also impaired, facial gestures, even though we use the gestures in the facial gestures more than our hands, and this can be involved or impacted as well. And finally, oral communication, the articulation of the voice as well. Classically, we are talking about this arteria, which is the involvement or the impact of the voice by a lesion. These muscles that can present with dystonia, stiffness, slowness of movements will impact deglution, and that's swallowing problems, which is actually called dysphagia. So I'll talk about the speech first on the left. This arteria has been called classically mixed dysertria from the Mayo Clinic from 1975 that we are still using, and it's called mixed because it has a spastic component. It can be ataxic because involvement of the cerebellus and it affects the rhythm, and kinetic because also it's similar to a Parkinsonism and slow movement. A patient might have all these signs, not really, maybe more spastic, ataxic, or kinetic, but these are basically these three main pillars. That's why it's called mixed dysarthria. So the main characteristics of speech and voice, and I will not deep dive too much on this, the articulation can be imprecise. This means that we are not articulating clearly all the consonants or vocals. For example, if I want to say good morning, I might say good morning. So it's not clearly articulated, all the different sounds and phonemes. The speech can be slow. It takes longer to start speaking, and then I speak very slowly. We might see inappropriate pauses during speech, and sometimes this might be caused by hyper salivation, or the patient needs to swallow saliva when it's at the middle of a sentence. So they stop their sentence, and once they swallow the saliva, there is that pause. Also, we find lack of coordination between breathing and speech. So sentences in the end might be not so strong, since we don't have enough air coming out. So if that air is not well coordinated, finally we're at the end of the sentence doesn't really have a lot of volume. And hypophenia, this means a low voice volume. So a low volume voice that sometimes is kind of difficult to listen to them, kind of whispered voice. The hypernasal resonance, all this voice, it's nasal speech with M, N, so that we get that feature as well. And we might find difficult to understand people with this nasal speech. And a monotonous voice with little melody, little intonation. So we're lacking exclamations and questions. So we don't really have the tone. And this might be a problem for communication, because if we do a clear articulation but we don't use the tone, they might understand the words but not the meaning that you are attaching to that specific sentence. That impacts obviously the intelligibility. And also it can impact on the quality of life of the person with WD. Frustration, fear, anxiety, low self-esteem because they might not be understood. So I'm not expressing myself, and then I'm around friends. I will be quiet. Will not express myself because they might not understand me, and that produces some frustration. Maybe they misunderstand me because I'm trying to say something and they keep understanding something else. They might think that I'm sad because my voice tone is monotonous, and they think that I'm sad, or I'm depressed, or I'm exaggeratedly happy or excited. So they might think that I'm always sad. That's not the case. It's just because I cannot express the happiness through the tone of my voice. And this can lead to this communicative isolation, because people stop communicating with people. They do not have a lot of relationships. Okay, I will not go to that shop because the lady doesn't understand me and will make me repeat everything. Okay, I will not go to the bank because there is a queue and people are pressuring me. I want to ask something and I'm very nervous. They don't understand me and I leave. And you stop eventually to communicate. Also, in terms of our friends, of our network of friends, I will not go there because I'm quiet. They look at me. When they ask me, they don't understand me when I reply. And then you might see the disruptions in the family, social and work environments. So not everyone will have problems understanding you. So you end up selecting the people. Okay, I will communicate with that and that person because they understand me better. But that leads to this communication isolation. So, right, speech therapists are here to try and improve as much as we can the intelligibility within all the different contexts. Of course, this depends on every person, every patient, but our goal is the patient to communicate as much and the best they can within their family, social and work environments. And we're not talking just about speech. We might use technology, we might use, we might combine. So I talk about communication, not just speech. Because yes, we can say many things without actually speaking. So we'll try to improve speech, but at least the idea is that the person does not stop communicating. There are just a few studies, not too many. And I'll repeat what previous speakers have mentioned. We need more studies, especially if we have a rare disease. We know that in Parkinson's there are not too many studies, so you can imagine in Wilson's disease how few these studies are. But we've seen in some studies that with the intervention of speech therapy, there are some improvements with the rhythm, the speech, hypernasality, and all that. And there is a study with highest level of scientific evidence that proposes a program that has been devised for Parkinson initially. This program has the highest level of evidence within speech therapy context because there were some MRIs done to Parkinson's patients before, and we identified the area of the brain that helps us to control the voice, and then few months later, the MRI was repeated, and then they identified that area was active. So the same area that was not working before the program, after the program, there were some neuronal interaction. So basically, they had improved their speech, and basically that shows that these also works with Wilson's disease patients. So this is a great tool, and it's a good insurance because this means that studies back how successful this is. But this needs to be intensive. And when I mean intensive, I mean like 3 times a day, 3 months, and that's how Americans are. A friend of mine did her PhD thesis in the United States, and she said, okay, I want to try this with Spanish-speaking patients and not just English-speaking patients. So in New York, the patients that she recruited, from Spanish-speaking patients, did not come. They would go once a week, and she was so tired she would not end up her PhD thesis, and so she sent us this email to the Parkinson's department of our association. So we recruited a number of patients, and then she managed to finish her PhD thesis, and the results were very satisfactory. So they had to be very so they had to do it like 3 times a day over 3 months. So we're creating new connections, new brain connections, new synapses. So we're talking about something which is very, very at the core of the speech. We're creating new brain areas controlling the voice. So I urge you to continue exploring these areas. So the sooner the better, actually. So it improves communication and improves also the quality of life. So patients should be referred when you see a patient like this. You should not wait until they have lots of speech difficulties, because we can actually do early intervention. And okay, now I'm going to turn to the swallowing problems. Above all, we see them in neurological forms of WD, but also in non-neurological forms, we can see these dysphagia forms. So a red flag here, and a message of caution that I'm going to launch here. So it might happen. So highlights here. Well, basically a lip closure deficit. So if we put the food in our mouth, if we don't close well, it falls. When we swallow any water or liquid, difficulty forming a bolus, a food bolus, chewing, delayed swallowing reflex. So when we are going to swallow, the activation of the larynx being elevated, everything closing, so it does, the esophagus closing, so it doesn't go to our lungs. Everything is slow. the residual food in the vallecula, in all the area around the mouth and under the tongue. Laryngeal elevation deficit. When we swallow, the larynx goes up and basically the esophageal sphincter closes, so it doesn't go to our lungs. And aspiration, which means that it doesn't go actually to our lungs. So we might get some bronchoaspiration pneumonia, dehydration, because obviously if every time I drink, I choke, I will stop doing that. And we might end up with dehydration, malnutrition as well, since I don't find easy to chew meat, so I will stop eating meat. Okay, this is too hard, I will not eat that. And then we reduce the groups of food that we eat, and then we might end up to malnutrition. And worst of all, might be choking, obviously, when the food goes into our airway. Probably there are a few more studies in Wilson's disease, and they have identified a clear deficit of pharyngeal motility. So the food, when we swallow, it runs through the pharynx, and then it goes, it's like there is this movement of peristalsis. And in Wilson's disease, that peristaltic movements are slower, and then you get these rests of food on the way, and this is dangerous. If we have this rest in the tract from the mouth to the mouth of the stomach, they can be aspirated because they might end up going to the lungs. So this is high risk, and with intervention, this could improve. We can improve maybe changing the texture of the food that we eat, eating and drinking simultaneously, several techniques, and can help us to improve this pharyngeal dysmotility. Another symptom also of dysphagia, this can present without neurological impact. It's the excess of saliva, hypersialuria, excessive or loss of saliva. So we stop swallowing. It's not that we are producing more saliva, we're swallowing less. So if we stop swallowing, and in a minute I would tell you what happened to you. Your mouth will be full of saliva because we are not swallowing this automatically without thinking. But that's something that we do it like 1,500 times a day. So if we don't swallow this saliva, it accumulates there. There is a sensorial deficit that the person does not realize that this is happening. There is an excess of saliva in the mouth, and basically the saliva runs more slowly. Then you end up with this amount of saliva in your mouth, and you haven't been swallowing because you're just talking. Otherwise, you're drooling. So this excessive saliva might be a first symptom of dysphagia, and I've been sort of battling quite a lot, so neurologists can defer the patient if they find this excessive saliva. No, when I ask them, they swallow okay, and then you look at the patient, and then the patient is drooling, and something is happening here. All right, today we're using botulinum toxin and rehab as well, but every case should be individualized, obviously. Right, we intervene through exercises, oromotor, work with the tongue and the pharyngeal and laryngeal elevation, dysphagia specific maneuvers. So with practice, there are different exercises to make sure that there are no rests. So bite the tip of your tongue and swallow. So you are cleaning basically from the back of your tongue all the rest of the food. Some people might tell you, okay, I hadn't swallowed okay because I had found some saliva here. Especially when you do this throat clearing as well. guidelines on consistency and volume liquids and food. We can use thickener for the liquids and trying to get a diet that is high on liquids. And also, the neuromuscular electrical stimulation is being studied for WD sort of patients, and there is an improvement on the swallowing process. So we place these LEDs on the basis of the neck, these electrodes here, and basically this helps to rehab these, to improve the muscles of this area. This is before the treatment with some rest, and this we can see at the bottom that there are less rest. And this is only after 10 sessions, once a week. So within a couple of weeks, you might have finished this therapy. Good news is that this improves this electrostimulation. Electrostimulation is practiced all over the place. Many hospitals, different sites, and specific speech therapy sites use this neurostimulation, this dysphagia electric stimulation. Some years ago, this was pretty new. Obviously, the equipment is costly, but I think that it's easier to have some access to this type of therapy. Also, we have identified some improvements in the neurologic level in patients that originally they didn't seem to have neurological involvement, but dysphagia. But after these exercises, their neurological impairment improved. So again, speech therapy intervention. Again, the sooner the better. Well, having access to professionals and a good diagnosis will help us quite a lot, and we have to be aware of the rehabilitation potential, and then we need to be deferred to consultants. And then, thank you very much for your attention.